treat everything really, as this nice poster sort of shows you, you know, head problems, neck problems, shoulder problems, elbow, wrist, thoracic spine, lumbar spine, hips, knees, ankles. We do it all. Be it a tendonitis, be it a ligament failure, be it a joint issue, be it a rotator cuff tear, Achilles tear, or tendonitis. We treat all of that. There's really nothing musculoskeletal we don't treat. And we have a variety of techniques, all designed to get you maximally recovered and without surgery. Next slide. So regenerative medicine is a newer way of using your own body structures, platelets, growth factors, stem cells, and other growth products that exist in all of us. We are able to extract those, concentrate those, refine those, and then inject them in you and help you heal in a much more powerful way than your body could heal originally. It wants to heal, but sometimes it just doesn't build the response big enough, hard enough to actually get the part healed. Needs a little help. And that's where we can take that healing further. Next slide. So what we're offering basically is a new option. Previously, you had the injury, and then you had some treatment with pharmaceuticals. You took anti-inflammatories, muscle relaxers, whatever. You may have went to therapy or saw a chiropractor, or did some acupuncture or some laser treatment or whatever. And chances are, if that all didn't help and you were still hurting, you were on your way to a surgeon. Well, now you have a new step, a new process that sits right nicely in the middle. And we can often help you never make it to that surgeon. It's not that we don't believe in surgery. We do, and we send lots of people to surgery. Surgeons, love us because we send a lot of cases. But we also save a lot of people from going to surgery that would have. A lot of people who were headed to knee replacements and didn't get them. A lot of people headed for a rotator cuff surgery, never had it because they got injected with stem cells instead and have a wonderful shoulder now years later. So that's what we do. We're the step that you should think about before you go to that surgery. Next slide. It helps to understand how your body heals, to understand what we do and how we can help that. So I'm sure most of you never gave this thought, but your body heals through an inflammatory reaction. That inflammation that you always try and get rid of when it's in a shoulder or a knee or an ankle is actually, if it's an acute case, in other words, it's a new injury, that's how your body mounts a healing response. It attracts all kinds of healing cells, platelets, macrophages, stem cells, and a lot of growth factors. And that all comes to the area of the injury. And guess what? That area gets hot, it gets swollen. Well, that's your body trying to heal itself. And that's the first phase of tissue healing, is inflammation. And the next phase is tissue regeneration, where you actually grow back to tissue and heal that tear or that injury that you had. And over a period of time, that regenerated tissue actually remodels to become strong again and to become more useful. And then you have complete healing. So what we do in regenerative medicine is try and restart this very basic cycle that your body does on its own. We try and restart it in an injury that's now, you sprain that ankle, it's now 6 weeks, it's done all the healing it's going to do. It won't restart on its own. But if we take some of your blood, extract the platelets, and inject those platelets into your ankle ligament that's torn or injured, we can restart this whole cascade again. It will inflame, new tissue will build, and then it will remodel that, and you'll have a more complete injury than when you tried to heal it yourself. Why? Because we're putting much more powerful things in. So this inflammatory cascade is important. It is how we heal when we're initially injured. Keep this in mind because, a lot of us think the very first thing we think of doing is taking an Advil or a Motrin, leave, and that's not what your body wants. Your body wants to inflame. So think about taking a Tylenol instead. Think about not using ice because it's an anti-inflammatory. Think about using heat instead for an acute injury, for an injury that you just get. So that's some basics. That's basically who we are, what we're involved with, the kinds of things we do, and sort of teed up the healing cascade for you so you can learn about some of these other techniques that we do. I think Dr. Newton is next, and he's going to tell you about some of these techniques in more detail. And I'm Dr. Friedlis, and I'll be back later to answer some questions. Dr. Newton, are you with us?
I can see you. I don't know if you can see or hear me.
I can both see and hear you. So
Fantastic.
take it.
Fantastic. Hey, sorry for being late. It's finishing a patient here. So thanks, Dr. Friedlis, for jumping in there. Dr. Newton, I'm one of the physicians here with National Spine and Pain and StemCell Arts, and it's a pleasure to be with you this evening. Thank you for using some of your time to get to know us and also get to know a little bit more about regenerative medicine. So Dr. Friedlis was setting the stage and helping us understand that a lot of us have issues of degeneration from overuse or from an accident, and we deal with acute and chronic pain. And some of the ways that we can help ourselves heal is by using our own body's machinery. And one of I'm going to go through a few of these more commonly used injections to help people heal. And the first one here is platelet lysate. So platelet lysate is used to really focus on nerve injuries, nerves, and even joints. It's like an immediate release of growth factors, natural anti-inflammatories, chemotactic factors that call over your body's immune system to an area. I like to think of these growth factors as you've all been in the supermarket before, and you've heard the person come over the loudspeaker and say, we need a clean up on aisle 4, clean up on aisle 4. Well, this is what the platelets are really good at doing. They can hone in on an injury and then tell everybody to come over and help fix itself, clean itself up. And so with the platelet lysate, we can take your blood, we can isolate the platelets, and then we bust these platelets open and use what's inside the platelet. And these platelets have tons of growth factors, things that are packed in there that we're even still trying to define their function. But we know a lot of them, and we know that these growth factors help heal things. And when you put them when we make this platelet lysate, it's almost like an immediate release of growth factors in a specific area. And for nerves, it's a very gentle type of injection. So it doesn't cause an acute flare-up of pain. It really just bathes those nerves and can help in the repair by establishing, as I mentioned, a cleanup crew. So next slide. All right, so the next thing is PRP. I think almost everybody who watches one of these presentations says, oh yeah, I know what PRP is. I've had it, or my buddy had it. And PRP is one of those basic building blocks of your body keeping itself together. When you scratch yourself or have an injury, the platelets are responsible for showing up on scene, stopping the bleeding so that you don't exsanguinate, you don't bleed to death, but it also creates a barrier so that you're not getting bacteria in. I'm thinking of a cut or a scratch on the skin, but also inside your body, they're responsible for showing up to an injury and helping the body organize itself to heal. And what's great about PRP is that most of us have it working. I mean, we all have it working all the time, but most of us can spare some of that blood through a blood donation like we would take from you. And we can then take that blood that we've drawn from you and concentrate it. And what's cool about the stem cell arts and Regenix platform is we can customize your PRP concentration to something that's very specific to the injury we're trying to treat. And what I mean by that is if you've got say a meniscus tear versus a tendon tear, you don't just put the same concentration and volume into each of these. They require some individualization. And what's great about what we can do is we have our lab that we're able to do that with right here in our offices. So our 2 offices are able to, we look at your injury, we say, I want something that's 10 times concentrated over the normal amount of platelets, and I want 3 cc's of it for a meniscus tear. And in the same setting, same visit, we can say we're going to treat the meniscus tear and a shoulder rotator cuff tear. That's a tendon. I don't want 10 cc's, I want 8 cc's, and I want it concentrated 15 times. We can do that, and then we can administer that to you in a very individualized and I think a highly specific way. And that's PRP is awesome for doing this type of trying to kick the healing process, that cascade that Dr. Friedlis talked about, into order. So next slide. And then we talk about bone marrow aspirate, or a lot of people call this stem cells. Bone marrow aspirate is where we take the marrow, usually from your iliac crest in the back. So this is not your hip, it's not your sternum. We can take it from any of these flat bones, but really the iliac crest is a large storage room where we're able to aspirate out the bone marrow in a relatively painless manner, and then isolate the nucleated cells from your bone marrow to then put them back into our targeted tissue. And these cells have multiple functions, whether direct or indirect on the tissue that you place them into or around. Next slide. We also have things, let's say that you've got a joint that's really just beat up, and it's so beat up that we don't think that you're a good candidate for platelets or even stem cells. We just think that it's, your range of motion is not very good. You've been told you're bone on bone, and we concur once we've done the evaluation and reviewed your imaging. And you're not necessarily ready for surgery, or maybe you're not a candidate for surgery due to age or medications. And so that doesn't mean we just take you out back and put you down. We have options. We have things that we can try to help you have less pain by using your own blood to create something called alpha-2 macroglobulin. And this is a large protein that is kind of like, I think of it like a sponge. When you put it into a joint area, usually a joint that's degenerating or has degenerated significantly, you get a lot of free radicals and metalloproteinases and things that are in the breakdown mode of the joint. And we find that if you can sort of stop that process, maybe bring the environment to a more neutral pH, that the pain can go down pretty significantly. And no, we may not be able to improve your range of motion in a joint like that, but if we can decrease your pain, you might be a lot more comfortable doing the things that you have to do, the things that you want to do. And I think that's part of what we're trying to help people understand is we're not just a one-trick pony. We have lots of options for you, and we can customize your treatment to fit your needs and try to benefit you to live your best life. So next slide. I think Dr. Wagner is next, and he's going to talk to you about some of the cool things that make us different and things that you might want to watch out for if you're looking around at the various options you have to do stem cells or regenerative therapies.
Thanks for taking some of your time out this evening to come listen about regenerative medicine and understanding what's the difference between kind of run-of-the-mill versus when you do everything in a laboratory and you're able to really quantify the number of cells you have, to concentrate them and accumulate them in a way that we have better outcomes and that there's research to justify what we're doing and to help us tailor how we treat you. And Dr. Newton mentioned some of that. Next slide. So I'm going to go through a few things here just to help you better understand the difference of what is stem cell arts and what makes us different. And the first thing you notice here on the right is an image of an MRI where there's been a rotator cuff tear in the tendon. You can actually see where that pointed arrow is. And then on the next slide, next to it is where they have changes in the tendon that have occurred as a result of treating it with regenerative therapies and actually have been able to gap that distance and grow that tendon. Now, that's not the case with everybody, but what we do know is that if we do a better job in concentrating cells, and we do a better job in purifying them, and then following the research that we've done on our patients, we get better outcomes and a higher chance that someone will have a success, like this image here. And that's actually an MRI image. So on the left, you'll see number one. We do more or less all of the versions of orthobiologics, of regenerative medicine. We do prolotherapy, a technique where we inject sugar compounds into the tissues and around it to stimulate low-level inflammation so the body recognizes that there's been an injury and sends the immune system there to try to repair it. We do PRP, as they've mentioned, which is platelet-rich plasma, where we take platelets from your blood, isolate them in the lab, and concentrate them in such a way, in a concentration that we know helps enhance healing to be better, more thorough, or faster, or more importantly, to reinitiate the healing phase. Sometimes we've taken anti-inflammatories, and as a result, we've kind of suppressed that healing phase. It helps us to feel better temporarily, but it actually helps to slow the process of healing. By reducing inflammation, you reduce the process. So you have to reinitiate it by introducing prolotherapy or platelets or bone marrow aspirate. And then you saw we also do bone marrow, which some of you would, there are actually some stem cells in it, but there are also other types of cells that are immunogenic and help you to repair. You see, we do alpha-2 macroglobulin. What they talked about is that protein that can bind all these inflammatory compounds inside your joints to help you to reduce pain. But we don't just do joints. You think of arthritic joints of the shoulder and the knee or the ankle, but we actually do tendons and ligaments as well. The ligaments are the tissue that hold the bones together and provide stability. Some of you have sprained your ankle before, and then afterwards you have a weak ankle. Well, that's because you stretched the ligaments, and now those are weakened. And we can go in under ultrasound guidance, and we can actually treat those tissues, the tendons that are injured, the ligaments, such as with plantar fasciitis or a ligament sprain in the ankle or a tendonitis in the elbow. The next is the lab platform. Now, the other providers had talked about how we actually take your blood or we take your bone marrow and we take it to our laboratory, which is in-house. Nothing ever leaves the property. Everything's labeled from start to finish. And we actually isolate the cells in the lab. We don't just put it into a machine and spin it down and say, hey, I think your stuff is in here. And the providers who do traditional tabletop PRP, they don't actually know how many cells are in there. They don't know how many stem cells you have, where we actually can do cell counts and do very precise measurements on concentrations of the cells that we have collected from you, and we can vary those concentrations based on what we need it for. So some diagnoses need more cells, some need fewer, some need higher volume, and that's been directed by the research that we have participated in with a number of other providers throughout the United States, so we can accumulate more data and do a better and better job. But you can really only do that if you have a laboratory to maximize your precision of the cells. And then below where it says number 5, we probably need to change this slide because we've been doing this now for probably almost 17 or 18 years. So we're not new at this. We're not beginners or dabblers. We're experts in the field. And if you have complicated questions or even simple questions, please bring them to us. That experience makes all the difference in the world in patient selection, realistic expectations, making the right diagnosis so we can pick the right solution for you, and then taking it to the lab and ensuring that we get those cells. Next slide. So more about the stem cell arts difference. On the right side, you'll see another image. This is an ultrasound image. And you'll see that little arrow, and what it's pointing at is a tiny little dot. That's actually the tip of a needle around a median nerve, which is the main nerve in the middle of your wrist that causes carpal tunnel syndrome when it's compressed. The dark around it is actually where we've injected solution, proliferant solution, or in this case, I believe platelet lysate, around the nerve to try to take off any of these adhesions or stickiness that might be pulling on the nerve, and then also to bathe it in those cytokines, those chemicals that actually help the nerve to be healthier and happier that we've acquired from your blood in the laboratory. But the point of that image is that the precision that we use has to be perfect under ultrasound guidance and or X-ray guidance, and have the skill set to actually use those tools properly. So you'll see number 7 is where we talk about the data registry. And that's basically where, again, we have about 60 providers or so around the country that are part of the network. We use the same selection process for patients, the exact same laboratory process for isolating cells. And that allows us to then follow those patients over time and collect data to see, how are you all doing? Are we getting the outcomes that we desire? Do we need to turn up the concentration or lower it? And what are the limiting factors as well that make someone a poor candidate? So that data is our data across the entire country that helps us to do a better and better job. And we have access to that data at all times, and it's continuing to this day to accumulate with different diagnoses. You can actually see some of that data and research on our website if you go to the stemcellarts.com, and you'll see outcome data, outcome registry, and you can pull down and read some of that if you would like to. Again, image guidance of the procedures. That means the precision is everything. Fluoroscopy is when we use X-ray guidance predominantly in sometimes in the knee and large joints, but also in the spine, so that we can put solutions exactly next to the nerves or in the disc in your back or the joints in your spine. The others, where we inject around nerves and tendons and ligaments, are all done under ultrasound guidance, such as that image you see on the right. So number 9, harvesting techniques. Most people, particularly when it comes to a bone marrow aspirate, they worry, is the bone marrow aspirate going to be difficult? Is it going to hurt? And everyone worries about it. And I get to tell patients it's probably the easiest part of the process. We'll often use a small amount of nitrous oxide or laughing gas when you do the procedure, which makes you, for the most part, not care so much. You can control it yourself. You can have more or less. But more importantly, we anesthetize and numb up the skin and the bone extremely well so that you experience as little pain as possible. And afterwards, the average person usually rates their pain scores a 2 out of 10 for doing the bone marrow aspirate. The number 10 is customizing everything. I talked about that, where how the lab allows us to customize the concentrations and volumes of cells that we use, and the data backs that up. Next slide, please. This is a simple example of highly concentrated and purified platelets on the right, the one that's clear and looks golden yellow. That's what comes from our laboratory. On the left is just a standard spin down technique that's not sufficiently eliminated all the red and white blood cells from it. Now, why is that important? The one on the right, the super concentrated platelets, allow us to get more cells, more concentrated and more purified, which ends up equating to better outcomes. And on the left, with the red blood cells in it, they actually interfere with the platelets' ability to do their maximal job. So you want to get rid of those. Next slide. So some words of caution. Remember, this isn't a magic cure. This can help many, many injuries that have from arthritis or tendon injuries, ligament injuries, and inflammatory tendinitis, those types of things. But it doesn't help everything. Make sure you work with providers that really understand the research and the data and have the best skill set possible to use the guidance such as ultrasound and fluoroscopy to get the best outcomes possible. If someone tells you it cures everything, you need a new provider. Allow us to help you determine which one of those techniques is best for you, the prolotherapy with sugar, PRP with platelets, bone marrow aspirate, or A2M. Then you'll hear about amniotics and placental compounds, where they've taken stem cells from the amniotic fluid around a baby, or from the placenta, or from the cord, And just know that none of those products are allowed by FDA. They've been banned. Additionally, none of them have live stem cells in it. So every once in a while, you'll still hear someone say, your cells are too old, which is not true, and you need to have these. Well, everything that's in those products, there are no live cells in it. Buyer beware. And then last, using fat to extract stem cells and inject is actually illegal by the FDA. Don't use fat for stem cells. Next slide. This is a simple slide that on the left is where you've taken bone marrow that has live cells from a patient, and the purple is where they have replicated and grown in the Petri dish. On the right is one of those products we talk about that they say, hey, we've got stem cells. Well, when they do have stem cells, they're all dead. On the right, none of them will grow. So please, again, buyer beware when it comes to amniotics and placental compounds that are said to have stem cells in them when they don't. Next slide. Dr. Dade's going to go through some of the more fun slides, if you will, which are real patients, actual images that you can come to understand how cartilage has been repaired or tendons have been repaired and end up in better outcomes for patients in pain and function. So I hope you'll enjoy this part of the presentation. Thanks for your time, everyone.
And I too thank you all for joining us tonight. And I'm the last speaker. We'll have some question and answers afterwards. What we're talking about is regenerative medicine. And of course, as we've mentioned, we do traditional interventional treatments as well, but regenerative medicine is our forte, and that's what our focus is tonight. So we're going to go through a little list here of our main areas that we treat. Now, it's not all inclusive. We're going to start with the shoulder, but we'll work our way down. But there's no elbow, there's no foot and ankles to a certain extent. And that's because we'd be here all night talking about regenerative medicine. We want to sort of focus in on what we actually do and how we do it. So you've heard from our three speakers already about what we are, who we are. We've talked about what we actually do, the processes that we do, and we hit a little comparison and contrast with Dr. Wagner. So what I want to do is show you, what does this mean to you? When all's said and done, and we'll talk about stem cells to start here. But how do you go about the process? Remember, what we're going to do is we're going to evaluate you first. And in that evaluation, we're going to say if you're a good candidate, a fair candidate, or a poor candidate. But that gives you information that you can use to say, hey, is this a process that I want to go through? So in this case, this is our shoulder. This is the MRI of the shoulder. And the red arrow on the left is a tear. So that's a large tendon tear. It's usually at the musculotendinous junction, meaning where the muscle and the tendon come together. Very common tear. This is your supraspinatus. So those of you who are have shoulder issues, you can sort of feel at the top of the shoulder here, and just underneath the trapezius, you have the supraspinatus, and that's torn here. So then you say, well, what do? I can go see my primary care physician. Maybe they'll send me to physical therapy. I can see a chiropractor, maybe get to the orthopedist, and the orthopedist says, hey, we got to surgically repair that. Well, like Dr. Friedlis mentioned, there's another way. And the other way is to put stem cells in that area that's torn. So what's the process? So the process is day one, we do what's called prolotherapy. And Dr. Wagner mentioned that's using dextrose, which is a sugar. And what we do is we irritate the tissues around this area. So make the capsule nice and tight and the ligaments come together. You need a tight joint in order for this to be successful. Meaning if you put stem cells in an area that joint's loose, obviously you won't get the optimal outcome. So what we do day one is prolotherapy. 2 days later, you come back for the aspiration. That means taking out of the stem cells out of your hip. And that's where most of your stem cells are. So we take advantage of that, and that's what we use. It's no problem. Later in the day, you're gonna come back and we're gonna reintroduce those stem cells after processing. We talked about that. But the point is, the key is not only the processing, but the location of where you put the product. So the product needs to go directly on the tear area, and it's now reinforced by the treatment we did day one. So that's day 1, 2, and 3. Well, 2 days later, after we put the stem cells in, you're gonna come back and we're gonna do PRP, platelet-rich plasma. And some of the reasons that we do that is we want the environment to be nice and healthy for those stem cells. They tend to do a lot better that way. So for this person here who had a supraspinatus tear in the shoulder, we did the stem cell process, and you can see on the right, again, it's a slow process. So those who want a quick fix, this may not be the treatment for you. But if you want a nice treatment as far as getting long-term improvement, this is a great treatment. So what we're showing here is the improvement in the tear. It's not complete. And that's after 10 months. So it's not complete, but your healing has started to occur and you feel pretty good at this point in time. So this applies to pre, meaning before you do surgery, and post-surgery. So a lot of folks out there have problems post-surgery, and we're going to talk a little bit about ligaments, the critical tissue in the body, which are your ligaments that support the bony structure. Next slide. So moving forward, this is your spine. So this is a lumbar spine, but it applies to your cervical, your neck, as well as your thoracic. So what you see depicted here on the far left in the red dotted area, large disc herniation. A very large disc herniation. You can't miss that. So we're looking right down the middle of this MRI and looking at the disc. That's a disc that's pushed out, causing pain along the nerves, which are sort of up and down along the back of that disc herniation. So you get the sciatica, you get the classic radiculopathy down the leg. Quite painful, by the way. So what do you want to do? So what do? You go see your primary care. They'll give you some muscle relaxants. They'll give you maybe some Grease, maybe some non-steroidal anti-inflammatory, but that's not going to help this a whole lot. So then you may see a pain management specialist or orthopedist or neurologist, and they send you for an epidural. So you put steroids in that area. Well, it's still not helping you. Well, what do you do next? You want to cut that disc material out. Remember, that disc material is critical as we all age. As we age, we lose our height, and our height is lost through our disc. The discs are made of mostly water. The body's about 75% water. The discs are almost all water, and you know they get narrower and narrower as we get older and older. So you want to maintain as best you can your disc material. So what do? Well, in this case, we did platelet lysate. You may recall what platelet lysate is. That's where we fractionate or break open your platelets, your healing cells of the body, and we put them in a concentrated amount at the site of injury. So that's what's done on right there in the yellow dotted area. So what happened was this disc, after a platelet lysate procedure, basically it's an epidural with your platelets, the disc resorbed. And that's a beautiful example of that disc going back into place. It resorbed, it went back in. And guess what? The rest of the world does it this way. In the United States, we tend to do surgery a little quicker than most people. But if you can get through that pain period and make sure you don't have loss of significant amounts of strength, we can get resorption to occur. And what you have on the right is really what we call axial views, or if you cut yourself in half and look down from the top, you would see the same thing. The big disc herniation here in the before picture, and you can see the resorption on the far right picture. Those little dots there on the far right picture are actually the individual nerve rootlets that go down the spinal cord itself. So that disc herniation was occupying that whole area, and with resorption, it's gone back into place. I will say this. Oftentimes with this, the reasons you have a lot of these disc herniations is because the force and torque and shear, meaning along the spine. Remember, the spine's held together by ligaments, and the ligaments get a force or a torque or a shear, which puts pressure on the disc, which hits the nerve. That's the process. That's the process all the time, because what happens is with the healthy disc is that pressure pushes out the disc, hits the nerve, and we need that resorption to occur. Now, as we all age, it becomes degenerative, meaning the bones wear and tear, and you get the spurs, you get the arthritis and whatnot. So, but typically we see disc herniations. This is the process. Next slide. So coming down the body, this is our hip. So MRI of the hip. Oh, there you go. MRI of the hip. On the left, the yellow dotted area is a tear. It's what's called a labral tear. In your shoulder and your hip, you have a labrum, and that's a tissue that surrounds and keeps the joint in place. It's a soft connective tissue, if you will. So that tears quite often as we age. Usually after the age of mid-30s, you'll see labral tears. It's not uncommon. There's large tears and there's small tears. Most people get small tears in your shoulder if you're doing a lot of throwing or weightlifting. And you'll say, wow, my shoulder is hurting a bit. Or my hip is hurting a bit when you're doing squats and lunges and thrusts. All these things contribute to wear and tear in the hip and the shoulder. So you'll see these small labral tears, and that white area in the dotted area is the actual tear. So what happens is the labrum is not confluent, means it's not the same all the way around. You can see the dark area around the hip, all the way around the hip. You see that dark area, and then that's the tear right there. So keep that in mind. So what we have to do is, in this case, we precisely put stem cells into that area. You have to do it precisely. If you just toss them in there, you will not get to the area of injury. This is a critical piece. It has to be done under guidance, combination of usually fluoroscopy and ultrasound, most of us use in this case. But the point is, if you go to the right, you see now the confluence is starting to occur. You can start seeing it looks smooth, it looks contiguous. Everything looks about the same. And it's about a 6 month to a year process. So it does take time. But the point of it is that this is another alternative to undergoing surgical intervention or living with pain, certainly. So this is a good treatment, not only for the hip, but also for the shoulder. Next slide. And moving our way down, this is our knee, our meniscus. You can see on the far left, the red arrow has a tear, a linear tear along that meniscus. And it's a tear that puts pressure on the bone because it's through and through the meniscus. So the point is, you have to get that tear improved. Otherwise, you're going to continue to have pain and disability in any type of activity you do, from walking to stair climbing, whatnot. Very common injury. So fast forward, we put stem cells in there. Remember the process. First, we do prolo around the whole knee, and then we do the aspiration and the re-injection. Re-injection has to be accurate, and then we do the platelet-rich plasma 2 days later. So what you're seeing here is nice confluence of the meniscus. So it's nice, it's smooth. That space has been occupied by the stem cells. And again, you're just seeing more of that on the right here. You can see where with a red arrow, where the tear is clearly delineated. And then further as the process goes, that tear is improving with the yellow arrow. It's actually gone. So this is a very classic example of how we can use stem cells in a meniscal injury, not only in the knee, but also in the ankle as well. So it's a great depiction there. So this is sort of along the same lines. On the far left, this is your ankle. So this is the yellow dotted line. If you look closely, is the actual disruption of the articular cartilage where things come together. And so that's an actual damage to the cartilage. And the reason you kind of know that from a medical perspective is because below that, in the white dotted area, you see cysts. Those are bony cysts. Now, bony cysts can be anywhere, but in this case, the reason those cysts have occurred is because the pressure from that chondral defect, that tear along the cartilage, is putting now pressure on the bone, where it usually spreads the pressure across the chondral area, across the cartilage. But now it's directly into the bone, which causes cysts. So that means there's pressure on the bone. So after a stem cell procedure here, where we lay over the cartilage to give it thickening, you can see, fast forward all the way to the right, you can see that the cysts are now gone and the cartilage is now smooth and contiguous. Cysts are gone, pressure's off, and the contiguous nature of the cartilage is there. Very critical. And that's a good outcome. Now, remember, not only will we treat this direct area, but the ligaments and the tendons, and they're also involved in this process. So we will tighten those ligaments, tendons, and joint capsules to make them strong, because you have to have inherent strength in those, because that's where the bones are articulating. Next slide.
Hello, Queen. Are you wanting to leave your corporate job, but worried about losing your income or?
So this is an example of what we do and how we do it. So we have procedure rooms at Tyson's and Chevy Chase. Those are our two locations. And we're using fluoroscopy here on the left, and you can see sterile drapes. You can see sterile technique. So this is a critical piece of how you do these procedures. It's not a slam, dunk in the sense that you come in and just get it shot into you and you go home. That's not what this is about. This is precision at its best. Thing here in this case, we're looking at the kneecap, the top right picture, and you can actually see two little needles in there. You can see one into the kneecap at the top, and then one into the joint space right there. And so what you're doing is you're treating some of the osteoarthritis behind the kneecap. That's where arthritis tends to start first in the knee, behind the kneecap, because we kneel down on our knees and whatnot. But this patient had what's called an osteochondral defect, which just means a lesion, a bony lesion. And so that's depicted in the white at the bottom, that little white area just above there, that little circle. There you go. That's our kneecap with the lesion inside of it, a bony lesion. And you have to treat that lesion or the patient won't get complete improvement. So not only do we treat behind the kneecap where the osteoarthritis is, but we also treat that osteochondral defect. So this is a prime example of how we use a multitude of treatments to get you better. Next slide. Of course, we all want less pain and improved function. That's the holy grail, but we also get with that improved mood, and we like to get patients off their medications. So we see a lot of patients that are on medications with the intent that we are trying to get them off of those medications. And this obviously gives you a better lifestyle, more active lifestyle. Next slide. And this is these are activities we all love to do. And now that COVID seems to be receding, we can get out there and do a lot of these things. Next slide. So again, we're at Chevy Chase and Tyson's. You've seen all four doctors that actually do regenerative medicine in our practice at the StemCell Arts Center. So these are the numbers. So what are we going to do? We recommend you make an appointment, come in with all your information, your MRIs, your bone scans, your CAT scans, your x-rays. You can sort through that. We're going to do an assessment, and we're going to say if you're a candidate for these treatments or other treatments, by the way, or maybe you're referred to a different type of doctor. But the point is we're all MDs and we treat patients on a regular basis with musculoskeletal problems. And any questions?
Hey, everybody. Thanks for those of you who watched our video. We appreciate you spending time in your afternoon to learn about regenerative medicine and stem cells and how we're using your own body to heal yourself. Certainly, there can be a lot of questions from folks, and I'll try to answer them as easily and as quickly as we can. I'm not exactly sure how to get the questions popped up here, but I've got a participants, couple of them here. I just don't know how to get you to the questions. If you want to raise your hand, or if you raise your hand, I can get to answer them as much as possible. So I'm going to just I will let's see if I can get over here and do some questions in the chat. So okay, so we have a question that says, typically how long does the treatment last if effective? It's a great question, and it depends on how bad the condition is when you present. Certainly the earlier in your sort of degenerative process, the expectation is the better you would do and the longer things would last. In fact, there's an article published recently about that. Some folks were trying to take adipose tissue, isolate the stem cells and the totipotent cells from umbilical cords and say, okay, if we put these in early osteoarthritis, does that make for a better outcome? And they were able to show that to some degree. So I think it's if you've got grade 4 cartilage loss, so you've got no cartilage at all, your knee is deformed, it doesn't open all the way and doesn't close all the way, it's safe to say that the stem cell and or the progenitor cells, the regenerative process is not going to be as maybe helpful to you. If the procedures and treatments give you lasting benefit, we've seen an average of 5 to 7 years on most large and medium and small joints. Tendons and ligaments once they're better for a good long while, unless you tear them again. Hopefully that was helpful. Let's see, another question from the panel. Are you the same at Regenix in Brooklyn or New York City? Yes. So Regenix is a by company name. It's spreading its protocols throughout all of the Regenix providers. So you should get the same treatment in Brooklyn as you do in a New York office, as you would in DC here, as you would in Colorado. We're all trained at the Regenix head facility. There are a handful of us who did a fellowship out there for at least a year and got some very specific training over a long period of time. But any Regenix provider has been vetted by Regenix and okayed to do most of the Regenix, if not all of the Regenix protocols. Let's see, let me get a couple of people who've raised their hand. Let's see, so we've got how difficult it is to see if a patient is a good candidate. Is it normal to say that the chance of success is 75% due to legalities, or is it based on previous data? Yeah, so what's cool about Regenix is they actually keep a record of patients that come through their offices. So if you were to come see us, we would rate you as a good, fair, or poor candidate based on our exam, based on the imaging that you would bring to us or subsequently send to us for review. And if you are deemed a candidate, we would tell you a ballpark figure of what percent we think you would improve by doing the procedures that we're proposing. And we can't, I can't tell any like the masses that, hey, if we treat your knee, 90% of you are going to be 95% better. That's impossible for me to know. But if we've done an exam and we've gone over your imaging, I can give you a good estimate of if you're in a fair candidate range, you're probably expected somewhere between 50 and 65% improvement. And that improvement should last a number of years. Some of that, the duration of improvement depends on what you're doing. So if you're jumping out of airplanes and you're wondering why your back, knees, hips, and feet hurt, we may recommend that you change some of the things that you're doing. And it sounds silly and it kind of being obviously dramatic, but I happen to be a triathlete. I like to run, bike, and swim. If I've got a bum knee and it's got maybe grade 2 cartilage loss and we've got some instability and bony changes, I'm going to say to that person, hey, we're going to reinforce the knee as much as possible. We're going to get the ligaments tightened. We're going to put layers of your stem cells from your back into the knee. And we're going to see if we can't get the knee to stabilize, improve itself. But if you continue to run hard miles and are kind of asking a lot of your body, you may find that you feel better, but it doesn't last as long. And so some of this is just it depends on what you're doing, how you're doing it, how often you're doing it, how hard you're doing it. And again, it's looking at your body makeup, looking at what you're eating diet wise, how much you're sleeping. All of these components help in the regenerative process. Another question is, how does age affect your stem cell count? We know that as we get older, the stem cell number that we have in our body, it's not as numerous, and those cells take a lot more stimulation to react. So there's less receptors on their core, on the wrapper around the cell. You need a little bit more stimulation. And what's great about our abilities in the labs that we have in our offices is that we can say, hey, if you're 68 versus 28, a 68-year-old, I'm going to make a stronger cocktail of PRP to activate and help promote the process or success of the stem cell at a 68-year-old versus a 28-year-old. I'll still use platelets in with my stem cell milieu, but I'm going to try to, I won't need as much stem cell, I shouldn't need as much platelet concentration It won't need to be as high, and the volume doesn't need to be as big of the platelet milieu to get the stem cells to do their thing. Another question is, are we covered by Medicare? Medicare does not cover generally these regenerative processes. And we're hoping that in the future that may happen, but I'm not holding my breath at the moment. Let's see. So someone asked, for example, for the knees, length of time to complete treatment is ideally what? If I have to travel to you, what would that look like? Great question. So we get people from all over the place. And so if you decided to come here and we're looking to have a stem cell treatment where we're actually taking your bone marrow and cleaning that up to isolate the stem cells and the nucleated cells, you'd be here for roughly a week. Some people will try to do their procedure in 3 different steps, which is typically what we recommend. So like on a Monday would be a pre-injection, on a Wednesday would be a stem cell draw and processing, and then re-injection with the nucleated cells and the platelets. And then on the Friday, you'd get platelets again from a blood draw from your arm. That blood would then be isolated and put into the area that we've recently just put the stem cells. And the idea again there is that if you've got stem cells in an area, these nucleated cells, they are active, but they become more active and more stout in their sort of their job because of the platelets that you put in there. So we find that putting platelets at the time of stem cell placement, as well as a couple of days later, you get the most biologic activity. See, I'm just trying to stay up on these questions, guys. So let's see. Is there any pain in the 3-day process? I would say we're using local anesthetic into the area of injections. So if we're targeting your knee again and your meniscus is the focus, we're going to put numbing medicine in the skin around the meniscus. And usually I put a little bit of numbing medicine in the actual injectate, knowing that lidocaine is not the best thing to use. We tend to use a little more of the ropivacaine numbing agent, and it lasts a little bit longer than lidocaine. Most people's recovery from these types of injections is some soreness, pretty good soreness for about 72 hours after putting the stem cell milieu into the body part. Some people will do well to take some stronger medicine like a Tylenol number 3 or Vicodin for a few days. But most people drop down to their baseline pain within a few days and will feel more stiff and more sore generally for a few weeks as you're having these cells churn and burn and try to do the things that we would want them to do to push them into making the environment in the joint or the ligament and tendon to improve themselves. Let's see. What do you have to do to recover from the knee procedure? Can you walk around after? So again, going to the knee, it depends on what the injury is. If we're trying to layer the bone marrow concentrate into the area where, let's say, you've lost cartilage on a surface of the knee, and we're really trying to see if we can build that up or improve that part of the knee, then we're going to say walking may not be the best option. So crutches or even a wheelchair for a couple of days may be helpful in not putting direct pressure right on that surface. From there's some weaning off the wheelchair to the crutches to one crutch to short walks, all within several weeks, anywhere between 2 to 4 weeks, depending on the person, depending on how big of a process is going on. So how does PRP biologics actually help tighten tendons, ligaments, and that are loose and stretched? Is the process similar to torn muscles, laying down scar tissue that forms a matrix where you lose range of motion? So the idea is if we can get your body, if we're using biologics, again, using your own blood, your own bone marrow aspirate, if we're taking that out of you and putting it into a torn meniscus, a torn tendon, a torn muscle, an arthritic joint, our goal is to let those cells be biologically active and do what they're supposed to do, which in general is to repair and reconstruct. And so if you've got a torn ligament, let's say, and there's holes in your ligament, or it's stretched out and it's sloppy, if you put these elements of biologics into a ligament or tendon, the hope is that it repairs not as a scar, because a scar is not very flexible. We want a stretchiness back to some of the tendons, and the ligaments should have a little bit of play to them, but not too much. By putting these biologics into the tendons, ligaments, and such, we're hoping that they will remodel themselves as regular tendons and ligaments, not as scar tissue, because scar tissue just tends to not have the stretchiness, and then it just re-tears. And that's part of the reason that people end up going to surgery, is they've had either too much cortisone in the area, which has told the body not to respond at all, or they've had they've keep playing through an injury that hasn't ever gotten itself back together in a way that's got some good integrity to it. Someone asked if this can be done in a diabetic person. Yes, it can. We know that diabetic folks tend to, depending on how well controlled the diabetes is, tend not to heal as maybe as quickly or as thoroughly as someone who does not have diabetes. But the same would go for someone who's got hypertension or hyperlipidemia, diabetes. If those are all unchecked or unmanaged, you develop sort of a general term is called metabolic syndrome, where your body it's not in the optimal state for healing. And so by putting platelets or putting bone marrow aspirate into an area doesn't automatically mean the body's going to go, oh, okay, we got it, we're going to fix it. It means the body may react still, but it's not going to be as smooth, as quick, as efficient, and it may take more than one treatment to get you maybe go in the right direction or even get you healed. So if you're poorly controlled diabetic, I'd say more important than getting the knee cartilage or the joint feeling better is to get the diabetes under control. And I know there's sort of a what do you call it, cat and mouse thing there, where it's like if your knee hurts, then you can't exercise, and that means your diabetes may be harder to control. But there are ways to exercise that don't require load bearing, such as swimming or other things like that. So certainly happy to talk to folks about that if they come in and see us in the office. General costs. So someone asked about cost or insurance acceptance. So generally speaking, insurance does not cover stem cells, does not cover PRP, does not cover prolotherapy, and some of these regenerative things that are very common and have been around for 25 years or more at least. And lots of questions are why not? And I can't answer that specifically. That'd be a long debate. It'd take too long for this forum. But general costs range anywhere from a few $100s up to, can be $10,000 depending on what you're doing and how you're doing it, how much you're trying to cover, how many joints, how many locations, etc. Interestingly, there's Regenix has been working on trying to help more people get covered for this type of procedure, and it's nice to see self-insured companies reaching out to their insurance companies to say, hey, we want to have this type of regenerative medicine available to our employees, and we're seeing that. I think there's more than 2 million lives covered at this point, maybe more since I last talked to Dr. Centeno out there in Colorado. And that's a huge number of lives covered, meaning there's companies out there that are giving their employees the opportunity to choose maybe a surgical route versus regenerative route. And traditionally, it's been more the surgical routes covered, and the other stuff's kind of thrown out the window. So if you're curious about whether your company is self-insured or whether they have this option, talk to your HR department. And if they don't do that, maybe ask them to look into it. Let's see. How do cardiac patients do with the process? Are there any side effects I'd need to be concerned with? Depends on if it's treated cardiac problems or current cardiac problems. I would assume that if you've got like a past MI and you've got stents, or if you've had bypass, we're usually okay with that as far as doing treatments. If you're currently experiencing things like AFib and you're on a blood thinner, and you may have like a heart monitor or a defibrillator, that kind of thing, we'd have to talk. Usually you're not as good of a candidate because we don't like people to be on blood thinners. Number one, as we're trying to draw marrow, you can imagine that could be pretty bloody if you're not clotting. Certainly if we're taking blood from your arm and you're not clotting, that can be that's leads you to be leaky, and being leaky is that's more detrimental than helpful. So I guess that question would need to be answered sort of on a personal basis of you coming in the office. Let's see, someone, I'm getting to kind of the last few minutes of being able to answer questions here, but one question is, can you use ultrasound in the office to monitor rate of repair or lack thereof instead of frequent MRIs during the process of healing? Absolutely. We have a couple of ultrasounds in the office that we use for initial evaluations and for follow-up evaluations once we've treated somebody. Some things are not easily ultrasounded. For example, discs in the spine. You can see certain areas of the disc in a spine, but you can't see the whole disc to know if it's protruded out or herniated out after you've done injections around the spine. The labrum in the shoulder and the hip, you can see parts of the labrum, but you can't see the whole thing at the same time. You can't see the deeper cavities where the ball is really up there in the socket. And so an MRI would be a better choice there. Certainly cartilage, if it's out of sight, just because the angles of bone covering the joint, sometimes an ultrasound just cannot see that based on the physics. And so we ask for MRIs. And those are typically gotten somewhere 4 to 6 to even 9 months after a stem cell or a bone marrow aspirate procedure. So I got like maybe 2 more here. One of them's, let's see, my husband's 74 and has very painful bone-on-bone shoulder arthritis. In your experience, what procedure has been the most successful? Bone-on-bone arthritis can be very painful for some people, and other people doesn't bother them. They feel a rubbing going on when they're moving their shoulder around. What I would tell you is if your husband has good range of motion, or at least decent range of motion all the way through, I would try something like the bone marrow aspirate, or maybe even something called alpha-2 macroglobulin, which is a huge protein that can be collected from your blood, put into the joint, and it acts as a sponge for the free radicals and the metalloproteinases that can really decrease pain for months at a time. We often use this A2M on people who have what would, bone on bone or end stage joint failure, and you're just not ready to get a new joint yet. The other alternative to treatment of a bone on bone shoulder, if you don't have any range of motion, stem cells, bone marrow aspirate, PRP, magic pixie dust, none of that stuff's going to open the shoulder up and make it move. So if you're looking for some type of regenerative therapy, it would be to help the pain, but it wouldn't be to improve the range of motion. So in all of our cases, if you don't have range of motion to begin with, doing platelets, doing bone marrow aspirate, also known as, the stem cell stuff, you're not going to magically gain a bunch of range of motion, maybe 5 degrees or so, but you're not going to gain a huge amount of range of motion because it's likely that the bones have actually changed shape enough that they've gotten in the way of themselves. And that, in that case, depends on what your goals are. But if your goals are just pain-free, then it's maybe you try this regenerative process. But if it's pain-free and range of motion, probably looking at a surgery if you don't have good range of motion to begin with. So let's see, you got one more here. Someone says lots of back pain, L4 and L5. So I'm not sure if that's a question or if just that's a statement for all of us. I would imagine, obviously, if someone's got a lot of back pain at L4 and L5, that can mean a lot of things. It can mean your discs are blown or worn out. Maybe they're pushing on some of the nerves. The nerves can cause radiating pain down the legs and across the back. If you've got discs that are worn out, you probably also have facet problems, which are these joints on the back of the spine. Those joints can be quite painful with sitting, standing, leaning backward, twisting. If it's the facets that are beat up, we can inject around those. If it's the discs that are beat up and they've got some height left to them, we can usually get in there and try to do some epidural work with the platelet lysate that you heard about earlier. So there's a lot of things in the regenerative world that people, maybe you've had it from somebody else, a primary care person doing it, a chiropractor that's doing it, even an orthopedic surgeon that's doing the platelets. And my experience with this is, and we're right here in DC, so we have people come to us that have been to Hopkins and Georgetown, and they've been to the hoity-toity places that have great practitioners, but we're dedicated to doing regenerative medicine. So we do this day in and day out, and we're using the tools that we have, the fluoroscope, the ultrasound, to see things and put needles in places that most people, if they're doing a knee injection with PRP, they just stick the knee in the joint, squirt it in there, and they're like, vaya con Dios. And they hope that the platelets or their growth factors, whatever they're using, they're hoping that with that one injection, that it's going to spread everywhere it needs to. And generally, it will spread a lot of places. But if you want a specific location, the proximal MCL, that's not even in the knee joint. So you want to get that, you want to put the needle right in that spot if that's where you're going. And if you got a meniscus tear that you're trying to work on and see if you can calm it down or get it better, you want to be right around, and maybe even in that meniscus, you want to address the coronary ligaments that hold that meniscus in place. If you're not doing that and you're just squirting it in the knee, you're gonna, I mean, I don't want to say you're gonna get what you pay for, but you might not be satisfied with what you got. And I'll be the first to say, I don't, we do our best. I do my best when we're trying to treat people, because I know it can be expensive and it can be time consuming, but this is another branch of medicine that is not new. It's been, I've been doing this for over a dozen years. My colleagues have been doing this for over a dozen years. It's been around for 25, 30 years in humans. It's been around in animals for longer than that. We've been doing regenerative medicine with prolotherapies of some type for even more than that. I mean, 75 years, they've been burning things to cause them to heal and putting acids in there and a volcanic ash to try to get things to respond, to get better. So the concept of having your body try to fix itself is not new. And we're grateful that we have the opportunity to help people, and look forward to seeing you in our office if we can. One thing I would tell you is, if you do come to our office, please bring CDs that if you wanted us to look at your shoulder, for example, bring the CDs of your shoulder that are 2 years old or newer, any x-rays 2 years old or newer. And we'll also be able to write you for prescriptions for either the MRIs, the x-rays, or CT scans, or bone marrow, bone density imaging, as well as doing the ultrasound evaluations in the office. So we want to help you get better and get back to doing the things you want to do, and look forward to seeing you here in either the Chevy Chase, Maryland area or the Tysons, Virginia area. Thanks for joining us this evening. I'm sorry if I didn't get to your questions, but look forward to seeing you in the office if we can. Take care.